by which we check the intraocular pressure. Today we will discuss tonometry and its different methods. Number one is the digital tonometry. Digital tonometry. It is with your hands digits. Okay. Number two, which is the most reliable method of checking the intraocular pressure, is the applanation tonometry. Applanation tonometry, and this applanation tonometer is mounted on the slit lamp. How it works, we will discuss. Then there is a Shorts tonometer. We will show you Shorts tonometer. Fourth is the air puff tonometer. Air puff tonometer is just like auto-ref, and when you push the button, an air jet comes out of the nozzle of the air puff, and it touches the cornea and applanates it and gives the intraocular pressure. Now, coming back to the most important point, the most important method, applanation tonometry. It is, as I told you, is mounted on the slit lamp. This is the picture of the applanation tonometer. Okay, this part is it visible? This part is the base of the digital tonometer, which is mounted, and this is where it attaches with the slit lamp. And this is the part which is a convex shaped, like this. Convex, sorry, this concave. Convex, it will be, when I will face it to the patient, it will be like this, concave from the patient side, so that, and its diameter is 3.06 millimeter, because after instilling the proparacaine eye drops, which are topical anesthetic, we will touch it with the cornea, and the cornea is convex, so it will fit into it. Getting my point? Are you getting my point? So it will fit into the cornea, and that is why it is 3.06 millimeter. And what happens? Here is a gauge, and here are readings from 0 to 9, and this is tonometer has two. I'm not going into detail of the optics. Two prisms. Okay, and when we on the street lamp, it uses the light of the street lamp, and it should make a circle, as this is a circular part. It should make circle. Besides proparacaine, for better visualization, we also instill fluorescing item and see it in cobalt blue light, and we see it in green color. So it should be visible like a circle. But because of its optics, we see it like this. Now this is very important. You know the optical principle of the prism, it displaces the image. In single line, simply it displaces the image. So you will see either this picture, it has broken the circle, or you may see this. Now what you will do? Here is the knob. Cornea is just touching the this tonometer is just touching the patient's cornea. Okay, and not you will push. Just it will applanate. Applanate means it will. If this is the cornea, it will just slightly press it, and this pressure, this force which is being applied to flatten the cornea is noted, and it is converted into millimeter of mercury. Are you getting it? Huh? Or difficult? This is the cornea. When it touches, it makes it flat by force, and that force is intraocular pressure. When converted into millimeter of mercury. Now, with the help of knob, what we have to do? We have to make the parts of the circles. These are called mires. M-I-R-E-S. Mires. We have to optimize the two mires when they are like this by moving this knob forward or in the reverse direction. When you attain this position, you note this reading from here. For example, it is 2. Multiply it with 10. The intraocular pressure will be 20. If it is 3, multiply, whatever the reading is, multiplied with 10. If it is 3, the intraocular pressure is 30. If it is 1, 10. So, this is basically the very important, I think, lecture regarding glaucoma, in which you have learned what is the optics of the tonometer, how it takes the intraocular pressure, and it is till now the most reliable method. Second one is the digital method of tonometry. For example, this is the eyelid when the patient is seeing downwards. This is cornea, okay, and this is the other eye. This is nose. This is eyebrow. Patient is looking downwards. Okay. Now what will we do? We will ask the patient to see downward after taking the consent. This is the forehead. We will place our fingers over the forehead, and with the index fingers, we will alternatively press the eyeball while the patient is looking downwards, like this. This. Can you see? I'm alternatively giving the pressure. The common mistake is that you people place one finger at the one eye and the other at the other eye. You have to do a fluctuation test on the same eye, and then you go to the other eye. Only with experience you can tell whether the eye is soft or hard. If it is soft, it is normal. If it is hard, then there is a probability that the pressure is high, and you will send the patient for proper IOP, intraocular pressure checkup. If the eye is very soft, then there is a probability that some disease like retinal detachment, in which the globe or some other reason in which the globe has lost its integrity, in which the intraocular pressure is no more maintained. Getting my point? These are the two important points, and I will finish my lecture by telling you just the real field effects. Uh, the neurological near field defects uh, respect the vertical line. For example, in pituitary adenoma, it pushes the inferior fibers at the chiasma, and what it causes bitemporal amyopia. Okay, and both nasal sides are okay, and this scotoma is not crossing the vertical line. But in glaucoma, the scotoma does not respect the vertical line. This is the optic visual field. This is the optic nerve, and optic nerve is a blind spot, means it does not have any photoreceptor. Therefore, at this point, normally, when we will spot it, when we will be doing the confrontation test and spotting the blind spot, you will see with a finger or pen that it doesn't. A normal person cannot see it, and almost 15 millimeter temporal to the, this is nose, temporal to the optic disc is the macula. Okay, these are the blood vessels. So this is the fundus picture. Now optic disc, uh, this glaucomatous damage in the visual field will be, for example, yeah, it will start maybe it will start from the optic nerve, because, and it may move in an arcuate manner. It is crossing the midline and going to touch the fixation point. It is called superior arcuate scotoma. And similarly, from here to the, this is point of fixation, inferior arcuate scotoma. You can call it double arcuate scotoma. This is I am drawing this because physiologically, when all the nerve fibers uh, converge into the optic nerve through their axons, they enter into the optic nerve through this vector. That is in the arcuate manner. They go into the optic nerve, and there is a maculopapular bundle which directly goes from the macula to the optic disc. It is usually resistant to pressure till the last time, because it is very um, thick and resistant to glaucomatous damage. And as anatomically the fibers are going into the optic disc, this is the same anatomical projection of the visual field defect. The only difference is it is upside down. Is it clear? Is it clear?
Yes.
So this is double arcuate scrotum. Similarly, there can be temporal defect, there can be nasal defect. There are it is called nasal step, or many other names which we will discuss later. But my basic intention today was to give you a brief overview of the glaucoma. I am recapitulating what we have learned. That you, by the end of this session, you have, in my opinion, learned what are basic types of glaucoma. You know the definition of primary open angle glaucoma. You know the symptoms. You know the triad, and you know how to check intraocular pressure by different methods. You know the difference between the neurological and glaucomatous visual field defects, and you know how optic nerve is damaged. This is the uh, basic, very basic knowledge which every undergraduate and every postgraduate must have. Thank you very much.